Hi, everyone. My name is Vincenzo Berghella. Once again, welcome to AJOG MFM Live, another live streaming event. Really excited today to have Rupsha Bolig with me as partner. Rupsha, can you introduce yourself?
Hi, I'm Rupsha. I'm a maternal fetal medicine physician here at Jefferson. I've been working with Vince for a few years now, and I'm excited to be here.
Yeah. At this point, you're more famous than I am, and I think at the end you'll prove it as well, which is great. We're going to talk about preterm birth prevention, vaginal progesterone versus 17P, the latest data from AJOG MFM. This is now, I guess, counting our ninth AJOG MFM live. The other ones are sitting in your Facebook, Twitter, YouTube accounts. Thank you for the thousands of you who have watched the previous one. You can still watch them. But today we're going to concentrate on an article that came out just 6 days ago. So really happy that we could do a live event on something that is really hot, just came out in our journal, AJOG MFM. And this is your meta-analysis on vaginal progesterone compared to 17P for recurrent preterm birth prevention. I'm going to give a quick background, and I feel like, again, I've been in this business for so long that the pendulum has swung so many times between 17P and vaginal. And we're going to concentrate today, again, on prevention of recurrent spontaneous preterm birth in patients with a prior preterm birth. And I thought the one message I could say after 30 years in the business, so to speak, are these three maxims from the temple of Apollo and Delphis, very, very famous. I actually love Nazi Sauton. I took 5 years of Greek, and knowing yourself, I think, is one of the keys to happiness and to really, choose your partner, choose your profession, be a good example to your kids. But the third one, I think, pertains to today thing, and certainty is madness. And I think at the end, we may give some recommendations, but this may change, in the next 6 months or 20 years. And so I'm not going to tell you that I'm certain about our conclusion. We'll go over kind of the history, the kind of pharmacokinetic mechanism of action background that you studied so well. And then again, you did a randomized study on this and a meta-analysis, and I'll let you go over that. Remembering in terms of history that progesterone has been around a while, was kind of discovered in 1934 and named, and I think the name is really important, progesterone, pro-pregnancy, pro-gestation, again from the Greek. And soon after, many, many years ago, we meaning, scientists that discovered that progesterone relaxes the myometrium. And then madness came around in the 60s, 70s, 80s, lots of randomized studies at the beginning, really on 17P. And I think one milestone was in 1990. There was a meta-analysis back then. Again, this is 32 years ago, but Dr. Kears, widely quoted, that kind of put together the first randomized studies on 17P, saying, or 17 OHPC, as we should probably say, saying that may work. And based on that, a good friend of ours, Paul Meese, part of the network, proposed a large trial, and did the trial that kind of changed the world. Was published, as you can see here, in June in the New England Medicine of 2003, 19 years ago. And I lived at Rupsha very closely. It was the first trial really in the network, in the maternal fetal medicine unit network. I think the best network in the world to do trials. That was positive, and Kathy Spong was the head then, and everybody else, FDA, CDC, NIH, Marshall Dimes, ACOG, etc. Everybody came out saying, this is great, we need to do it. We did a survey, and when we found out that before that trial, less than 10, 15% of people use progesterone for prevention of preterm birth for any reason. The only one I knew actually was our own Dr. Davis here, who were doing transabdominal cerclages, laparotomy-wise back then, and he was the only one using it for those patients. But then soon after 2003, went to 30, 40%, and then eventually a couple of years later, 2005, to 70, 80% use of progesterone for prevention of preterm birth. This is your slide, kind of, the last 20 years. I don't know if you want to chime on that, because first it was 17P, and then...
Yeah, I like this. Sorry, I was muted. I like this. I put two next to each other because I just wanted to highlight that while we have all this data on 17P, actually concurrently, similar studies were being done on vaginal progesterone. Many of them were not in the United States, and that's why we may not realize that sort of the history of vaginal progesterone goes back just as far as the history of 17-OHPC in examining prevention of preterm birth. So, the same year as the mice trial came out, Dave Fonseca did a trial looking at vaginal progesterone for prevention of preterm birth in high-risk patients. So it wasn't just prior preterm birth, it included multiple risk factors, but also found that vaginal progesterone reduced the risk of preterm birth in that high-risk group. And in 2008, when AJOG and SMFM recommended 17-OHPC for prevention of preterm birth, between that time period and now, there have been over 10 randomized trials looking at vaginal progesterone in the prevention of preterm birth. And so we do have a lot of data on both of these formulations in prevention of recurrent preterm birth. And
all of this data then kind of led to wide use. You want to comment on this slide?
Yeah, and this, you can see the, 2000, this starts at 2008, which is when the AJOG and SMFM recommendations came out, which, notably was a few years after the mice trial came out. But you can see really the great increase in hydroxyprogesterone, or the blue line is any kind of progesterone. And down on the green, though, is vaginal progesterone. And it's almost, you can barely see it because that number is so low compared to hydroxyprogesterone or injectable hydroxyprogesterone, which is the red line. And you can see that's really going up, and that's 17-OHPC here in the US. So although there's been data on vaginal progesterone and studies on vaginal progesterone, its use in the United States for recurrent preterm birth has not nearly matched that of 17-OHPC.
And I think, we may double check it. I think soon after the 2003 MEAS trial, it's when 17P kind of became hot and AJOG began to recommend it. And there were multiple publications and surveys and use. And then, like you say, vaginal progesterone came around, and I think confuses things in the way there's so many different things. So it'd be nice to go over, even if briefly, kind of the mechanism of actions, the pharmacokinetics, and you've done a lot of work on this. So why don't you walk us through that?
Yeah, this is a very basic graph on progesterone mechanism of action. There are a few different, and this is still an area under much study, but there are a few different ways that progesterone impacts or may prevent preterm birth. Ultimately, it acts to reduce cervical remodeling and uterine contractility, which is thought, to precede preterm birth. One mechanism, if you go to the next slide, is acting through progesterone receptors. So directly acting through progesterone receptors. These are ligand activated receptors. Ultimately, what the activation of the receptors leads to is uterine relaxation and prevention of cervical remodeling to help prevent those downstream steps leading to preterm birth. Progesterone also acts through non-receptor mediated mechanisms that relate to its effect on the immune system. So it acts through G-coupled signaling cascades that ultimately lead to an immune quiescent state. And that's thought to impact sort of the inflammatory pathways that may lead to preterm birth.
So vaginal progesterone, why the vaginal route?
So I like to start with this because, a lot of people ask this question. Patients maybe not want to take something vaginal. They may already have a problem with vaginal discharge. They ask, can I just take this by mouth? So this graph, this was an old study, and I'm sorry the citation isn't there. I think it got hidden, but it looks at injectable intramuscular progesterone versus vaginal progesterone administration. And you can see the white circles. With intramuscular injection, you get elevated serum levels. And with a vaginal administration, your serum levels remain low, but you have a marked impact on the endometrium. So you're getting a local effect of vaginal progesterone. And the theory in pharmacology is that vaginal progesterone is absorbed in the vaginal mucosa and undergoes a uterine first pass effect. So it's absorbed in the vasculature from the vagina to the uterus, and it passes through the uterus before it goes systemically. And that's why you have this primarily local effect. So what do we use? There's a lot of different formulations of vaginal progesterone. Prometrium is one of the original micronized progesterones approved by the FDA. It's actually approved for oral administration, and it was FDA approved, not for obstetric indications. More recently, you have a micronized progesterone endometrine, so that's a brand name, that is specifically FDA approved for vaginal administration. So it's the same medication, but it was specifically got approval for vaginal administration, and again, for non-obstetric indications, primarily infertility related. And then finally, we have vaginal progesterone gel, brand name is Crinone, also an FDA approved product. This is also vaginal progesterone, but the mechanism of delivery is a gel rather than a suppository or a tablet. And again, this was FDA approved, not for any obstetric indication, but for infertility and other gynecologic indications.
And you have this slide to kind of...
Yeah, so these are all bioidentical. So Prometrium, endometrine, Crinone, and their generics, they're all micronized progesterone. Prometrium and endometrine are suppositories, while Crinone is gel. And so there's some differences between a capsule or a tablet and the gel, and we could go into that. The gel, again, although it's the same medication, in studies, again, outside of pregnancy, with the gel, you have lower serum levels and a delayed absorption compared to, this study specifically was comparing it to endometrine, but compared to micronized progesterone suppository. Additionally, when they looked sort of with use over time, the vaginal progesterone insert, this is again endometrine, so a micronized progesterone suppository, reached steady state serum progesterone levels in a couple of days, while with the gel, the serum levels didn't reach steady state for several days. Again, same medication, different absorption. So in looking at suppository versus the gel, they have different pharmacokinetics, meaning you give a certain dose and it's absorbed differently over time. They are both FDA approved products, both for non-obstetric indications. However, both of these have been used in various studies on prevention of preterm birth. So these are both studied for the prevention of preterm birth, although neither are approved for any obstetric indication.
So again, you cover kind of the vaginal different routes and stuff, and today we're kind of discussing that part versus 17-OHPC. So why don't you go over that part?
Yeah, and the reason I like to start with the basics is I think to understand why they may or may not be different in efficacy, you have to try to understand how they're working. So 17-OHPC or 17-hydroxyprogesterone caparate has this caproate moiety, that's this little tail tagged on the end. It makes it very lipophilic. It increases the half-life, so it lasts a lot longer in the system compared to a natural micronized progesterone. They're different in how they seem to be different in how they're received by the body. We did a small study looking at vaginal progesterone in pregnancy. And while in non-pregnant women who will naturally have low progesterone levels, you do see a systemic rise in progesterone with vaginal administration. In pregnant women who already have high serum progesterone levels, there wasn't a marked increase in serum progesterone with vaginal progesterone administration. With 17-OHPC, this is a synthetic drug, so it's not a naturally found hormone in pregnancy, unlike micronized progesterone. Progesterone is a natural hormone in pregnancy. You do get systemic exposure. It lasts for days. That's why it's injected weekly. But 17-OHPC compared to natural progesterone does have decreased affinity for the progesterone receptors.
Fascinating. Go on.
And then just quickly, so before everyone falls asleep, again, I know not everyone.
No, this is so interesting, Ruth. This is, unless you know how things work, you really can't tell.
Yeah, no, exactly. That's exactly how I feel. And I don't pretend to know how things work, but I love these studies that are looking at it. So this was a study from 2015, and this was looking at vaginal progesterone versus 17-OHPC, and it looked at maternal fetal interface and cervix. So they did a few different studies along this line. The top chart is vaginal progesterone, and the bottom one is 17-OHPC. So you can see that with compared to control with vaginal progesterone, you have an increase in CD4 T regulatory cells. So again, that's like an immune quiescent cell, whereas you don't have that effect with 17-OHPC. In contrast, you have a reduction in your CD8 cell. So that's an inflammatory immune active cell. No change with 17-OHPC. And you also have a decrease in macrophages with vaginal progesterone and no change with 17-OHPC. So in this model, they found local anti-inflammatory effects with application of vaginal progesterone that they did not identify with 17-OHPC. This is another study, like I said, along those lines. So this is looking at inflammation. So it's looking at the membranes, and the theory here was looking at, membrane weakening. If the fragility of the membrane leads to PPROM, and so how might these medications prevent PPROM? And with vaginal progesterone, so here you have the control, the GM-CSF, that's their positive control. So we know that's something that causes membrane weakening. And when you have that same induced membrane weakening, that can be inhibited with progesterone. So you have, an inflammatory state that would usually lead to membrane weakening, but that effect is now inhibited with progesterone. And this same effect was not seen with 17-OHPC. And so again, you have your negative control. The first bar is what happens when you have membrane weakening. And then at the end, you can see that even with 17-OHPC, you still have that membrane, that GM-CSF induced membrane weakening. And so here we're seeing multiple levels of mechanistic ways that vaginal progesterone may impact prevention of preterm birth, and pathways that 17-OHPC may not be effective or as effective in modulating.
So I think, to kind of summarize this first part, which, may be the most interesting part, vaginal progesterone seems to make more sense. We do know that, pathways to preterm birth are multiple, but certainly the inflammatory one, it's one of the major ones. Certainly cervix seems to be very involved. The drug is right there. You showed the levels. So I think a lot of this data points to possibly, vaginal progesterone making sense from in terms of work. But we do have randomized studies, like you say, that compare vaginal progesterone and 17P. And you did one. I put here the pyramid because the level 1 data, I think, is the most important data. So please tell us. So we're going now from the mechanism of action and pharmacokinetics and tissue levels, inflammatory effects, etc., to actual patients be randomized to one drug, vaginal progesterone versus 17P.
So we did a study here at Jefferson. I realized in the beginning I forgot to mention disclosure. So this study was not funded. I personally have received funding from March of Dimes, NIH, as well as Covis Pharma, which is the company that took over AMAG. So Covis Pharma now produces Makina, which is the brand name 17-OHPC. I have grants from them that don't involve progesterone, but I have received financial grants from that company. We did a study here over several years, 2015 to 2021, comparing vaginal progesterone to 17-OHPC in singleton pregnancies with prior preterm birth.
And Ruksha, maybe I'll interrupt you here. What really, I saw you from the beginning, going over this. You gave it a wonderful name, the VIP trial, which I thought reflected who you are as well. What a wonderful researcher and clinician you are. But what really, possessed you, I guess, in some ways, so much work to do a randomized study to start this, and in a fairly, early age in your career. I had a preterm birth myself. I had lost my first pregnancy at 20 weeks, which you know well because you were literally at my bedside. And you know well that I sat in your office talking about what we could do the next time. And
and there weren't that many answers, I think is the main point. I had a lot of questions, and you didn't have a lot of answers for me. And so so really, this issue was really very important for me because I read your textbook, I read many articles, and I didn't know what the answer was. I didn't know what was the best way. What was the answer? For me specifically, I didn't have a short cervix, but I had a 20-week delivery. Why did I have a 20-week delivery? If it wasn't a short cervix, what was it? If it wasn't a short cervix, should I be on progesterone, or would that not be helpful at all? So I had a lot of questions, and there weren't a lot of answers. So
and you have your kids, behind,
yes.
Simon and Maya, and I know you don't mind, sharing this, and I thank you for being so open. You took 17 OHPC.
I took 17 OHPC. This study started, I'm trying to think, we talked about it before I delivered, but it had started after I was already pregnant. So our study started after I was already on 17 OHPC. I remember we talked about it, and at the time the AJOG recommendation and SMFM recommendation was, well, AJOG actually said to use either, but SMFM recommendation was specifically for 17 OHPC, and so I felt that I should just follow what the national guidelines were in the absence of better information. So I took 17 OHPC. I ended up with a short cervix at 22 weeks, and Dr. Roman, our cerclage queen, saved my pregnancy. So I was short and dilated at 22 weeks, and I delivered at term with a cerclage in place. And then for Maya, I really debated being on progesterone at all, to be honest. I was planning on a history-indicated cerclage because I already had a short cervix. I thought it would be a introducing bias if I enrolled in my own trial, so I didn't. And I ended up doing 17 OHPC again because I figured I already had the vaginal route covered with the cerclage. So if there was anything systemic 17 OHPC was doing, maybe I would try that. And honestly, I wasn't adherent to it. I stopped it, I think, at 30 weeks because I hated the injections. And I also delivered at term with Maya. She had a different set of issues, but it wasn't spontaneous preterm birth. So, even for myself, I didn't know what the right answer was. And even after one pregnancy and one outcome, I still wasn't sure what to do the next time.
Well, kudos to you for doing the randomized studies and then the meta-analysis we're going to talk about in the next few minutes. Really, really kudos to you. It's so much work. And I guess, another way to think of your background is, sometimes we go into trials with our own biases, and I think it's good to know, often, you start a trial and say, I think eventually this may work better than the other one. And then I think more often than not, my experience has been that kind of the results surprise us, and maybe this is one of those cases. But why don't you walk us through the baseline characteristics and the details of the study?
Yeah, so this was a trial at 5 sites, and big thank you to all the sites that participated: Bay State, GW, OHSU, Virginia Commonwealth University. It was a big effort, and as I mentioned, it was not funded, so it was a lot of groundwork by all the investigators that helped me out. We ended up with 94 singletons in the vaginal progesterone group and 94 in the 17 OHPC group. The study was designed to detect a 50% reduction in preterm birth, which is, I realize a large reduction rate. That's just what we were, able to power for, thinking about what would be feasible for me to do when I started this as a fellow. I also wanted to pick a reduction that would be significant and be clinically significant. There was, baseline characteristics. You can see this was at tertiary, urban academic centers. So we had a good proportion of Black patients, similar to the mice trial, in contrast to the prolonged study, which had a small percentage of Black patients. There was actually a difference in baseline characteristics. The vaginal progesterone group had a much higher percentage of patients who had had one prior spontaneous preterm birth. Now, this was randomized, so it randomly occurred that that's what happened, but that was something that we noted in our baseline characteristics. We did not exclude based on either cerclage or short cervix. So all the sites as standard of care, they offered history-indicated cerclage as would be indicated by history, and did cervical length screening from 16 to 24 weeks for women with a prior spontaneous preterm birth. And they all also offered, or actually recommended, cerclage for those with a short cervix. As you know, not everyone who we offer or recommend a cerclage to takes it. So there are some women, just a couple really, who had a short cervix who did not have a cerclage in place. The rate of both short cervix and the need for either ultrasound or exam-indicated cerclage was not different between the groups.
And I think, this detail is so important. Some of the other trials, like we'll see later on, excluded women with a cerclage, especially with a short cervix. And obviously, especially the short cervix is a big second, risk factors on top of the preterm birth, maybe even stronger risk factor. And, some other studies, even not on progesterone, say that women with a prior spontaneous preterm birth, up to 40% could have a short cervix less than 25 millimeters. So I think 25 in your study is reasonable. But if you're recruiting people in the US, people with a prior spontaneous preterm birth in a population like ours, quite a few, a third, a fourth, something like that, will shorten.
Yeah, and I think just to go back to that point, I think there's a few different things to consider. One is looking at what happened historically versus now. And I think that's important when you think about difference in trial results. Like, the May study, very strongly positive trial, was done now almost 20 years ago. Prolonged, not positive. There was definitely a difference in the rate of short cervix between those trials. You have a difference in these additive risk factors that may make you think about, well, is it that this medication doesn't work, or is it that study was in a different time in a different population, and maybe that data is not applicable to our US population anymore? And so it's a very important point. I also think I see like two sides of the story here, where you might say, well, you shouldn't, by studying short cervix, you're mixing the picture of risk factors. And my thought is that there aren't distinct risk factors. I think there's, preterm birth is multifactorial, and there is an interplay of risk factors that ends up leading you to an initial preterm birth or a recurrent preterm birth. And so I didn't want to exclude based on one risk factor or another risk factor, because the fact is, when you have a patient in front of you, they're going to have a mix of risk factors. And so I thought this was the best way to have data that would be applicable to most physicians and most patients.
And let's emphasize that fact even more. I think you and I think like clinicians. We saw patients today, we're going to see patients tomorrow. We do know, I think, from lots of other trials we're not going to cover today, that if you have a short cervix, no matter what your history is, vaginal progesterone seems to be efficacious. I think that's most guidelines everywhere, and that's what we certainly do routinely in the US. The thing is, you're probably not going to get a short cervix till, after 16, 18 weeks, while you have a history of preterm birth beforehand, and that's a major risk factor. So historically, you kind of think like that, and we'll go over maybe the fact that maybe some kind of progesterone could even prevent, the short cervix and then prevent the preterm birth. But let's go through your trial, and we'll come back to some of these very important issues.
So as far as outcomes, the primary outcome was preterm birth less than 37 weeks. The primary outcome was not spontaneous preterm birth. It was just overall preterm birth less than 37 weeks. So we found that there was a lower rate of preterm birth less than 37, 34, and 28 weeks in the vaginal progesterone group, but this was not statistically significant. We did find a 1 week later mean gestational age of delivery in the vaginal progesterone group compared to 17 OHPC, about 37 versus 36 weeks. You also looked at latency to delivery using a Kaplan-Meier survival curve. And in the overall group, there was a trend towards an increased latency with vaginal progesterone. P was 0.05. We did do a subgroup. We had some planned subgroup analyses that I'll share with you. We did a post hoc subgroup analysis based on just women with one prior preterm birth. And that was based on the difference in baseline characteristics because we had so many more women in the vaginal progesterone group with multiple prior preterm births. And so in looking at just women with one prior preterm birth, the vaginal progesterone group had a significantly higher latency to delivery. Another thing I looked at, so this was a pragmatic trial, meaning that progesterone formulation was not provided by the study, and it was ordered through participants' insurance. And I made it a pragmatic trial because, again, I wanted data that could be applied in the real world and clinical practice in seeing what actually happens to patients when they get one of these two medications. And we found that for the patients who were, so the gestational age at enrollment was similar between the groups, but patients in the vaginal progesterone group were able to initiate or did initiate progesterone about a week earlier than those in the 17-OHPC group. And almost all of them initiated progesterone prior to 20 weeks, which is what's recommended. There was a significantly higher percentage of women in the 17-OHPC group who initiated their therapy after 20 weeks. And that's important when you think about, studies that have been done looking at gestational age at initiation, specifically for 17-OHPC, that later gestational age at initiation is related to a reduced efficacy in preterm birth prevention. Once it was initiated, overall adherence to delivery was similar between groups.
And, I think you could also name this slide, real world use kind of thing, because, this kind of points out to the fact that, vaginal progesterone may be easier to, at least in our practice, a kind of a academic, US practice, easier to find. Obviously, it's cheaper, and initiation timing, it's extremely important, and continuation, obviously, it's extremely important. So I'm glad you followed this. I also want to point out on the slides, I forgot to say it before, that we want to thank the American Journal of OB/GYN, the great journal, really the premier journal in our specialty, to have publicized and published this data just last month, after, like you said, many years of work. Finally, it's nice that to see a journal like the Gray liking the data and publicizing it for all of us. So you had the randomized trial data. It took a long time and blood and sweat. And then we kind of always had it in mind that, there were other trials out there, and, before your trial and during your trial, and so to do a meta-analysis of those, which, again, is kind of the pinnacle, orange, systematic review and meta-analysis randomized trial in terms of the evidence, even if, you always find shortcomings in any data sets. But this is, to me, as good as it gets. So why don't you walk us through what you found? BOLIG 2022 is obviously your trial on this slide.
Yeah, so we had always planned to do an updated meta-analysis. When we initially designed the study, we had looked at a prior meta-analysis from 2017 that included 3 trials in directly comparing vaginal progesterone and 17-OHPC. And we had always planned, once this trial was completed, to do an updated meta-analysis. Previously, there's only one other study that was done comparing vaginal progesterone versus 17-OHPC in the US. And since completing our trial, we found 4 additional randomized studies comparing these two. This demonstrates, this first slide is really an important one to look at before you start looking at data, is to look at the quality of the studies included. And you can see that there were some studies with either singular or multiple high risk of bias. One thing is that none of the studies were blinded. So as was ours. Ours was also not blinded. So participants either got vaginal progesterone or 17-OHPC. It wasn't double blind, or they didn't get one injection and one suppository. The meta-analysis ended up including 2 studies from the US and then studies from Asia, Saudi Arabia, Iran. And We included trial registration, again, looking at quality of studies included and reliability of studies included. So some studies weren't registered, some were registered after enrollment was initiated. The most recent trials, and I think this reflects, a stronger emphasis on the importance of this, were prospectively enrolled trial registration. The type of vaginal progesterone varied, and that's why I started off by talking about what the different kinds of progesterone was. So we have vaginal micronized progesterone, dose range from 100 to 200 milligrams, and then one study that used the gel. The 17 OHPC dose was the same across studies, which was 250 milligrams weekly. And then finally, if you look at cervical length, most studies actually didn't include cervical length. And so our study included cervical length. A study from 2020 included cervical length. And some studies specifically excluded it or didn't assess it at all. Gestational age randomization was similar across the groups, and primary outcome was either gestational age of delivery or preterm birth, less than 37 or 34 weeks.
I wish that, everybody kind of included, the short cervix. I think that, that's one of the shortcomings of looking at this. Kudos to you to have included, the cerclages and the short cervices. But obviously, some of this patient may be, especially the two studies in which the short cervix was excluded, we've seen over and over those patients are at much less risk of preterm birth, and therefore, no matter what you do to them, they may do well, and an intervention may not make a difference if your upper risk is so small. Yeah. But nonetheless, let's look at some of the data, outcomes you had.
So this was the primary outcome for the meta-analysis was preterm birth less than 34 weeks. And so we found that in combining all the included study data, there was a reduced rate of preterm birth less than 34 and 37 weeks for vaginal progesterone compared to 17 OHPC.
And this, 26 to 24 percent, decreases are somewhat important, I think it's certainly significant.
It is, and it's also consistent with prior studies that have looked at risk reduction with progesterone in general. So it's not, it's within the realm of the kind of the expected risk reduction that you expect to see, except in this case, it's not comparing to placebo, it's comparing to another active drug.
Yeah, and it's important to also point out, when I do my analysis, I always try to do this, that, most trials go into the same directions, the dots, so to speak, are on the vaginal progesterone side with, one exception on a small study. So consistency of the data.
And then we also did a few different planned subgroup analyses. So one thing we did in this meta-analysis was to do a sensitivity analysis based on quality of trials. And so we looked at studies that had low risk of bias or high risk of bias, which was that they had 4 or more bias measures that were marked as high. And so when we included only those low risk of bias studies, the trend was in the same direction, but the findings were no longer statistically significant. And you could see that when you're looking at study size, so we have 4 studies here that are about the same size as one study, the Maher study, that was found to be high risk of bias. So when you half the included sample size, the results were no longer statistically significant. And you can also see in contrast, when you look at the risk reduction in the studies with low risk of bias, it's 0.87. So like I said, in that 10 to 20% range that we would expect, progesterone, or that other studies have found progesterone to have as far as risk reduction. And when you look at the studies that are at high risk of bias, you have a much higher, they've identified a much higher risk reduction as well. And we did a few other subgroup analyses. So one was looking at difference by dose of progesterone. And when you're starting off with, although it was 7 trials, the total number of participants was limited, about 500, 550 in each group. So you are losing your power here. But we didn't find that there was a difference in dose. Most studies used vaginal progesterone 200 milligrams. That's actually based on prior studies on progesterone and preterm birth. Most of them also use the 200 milligram dose, and that's how we decided to use the 200 milligram dose for our studies. And then there's only one study that used the gel.
So you have a few points here in terms of, trying to find, the patient in which, one or the other may work better. So why don't you walk us through that?
Yeah, I think one of the sticking points that has driven me in the studies that I've done is really looking, because the results have been so mixed. And I think it's frustrating for all of us as clinicians to have one trial that says one thing, another trial that says another thing, one meta-analysis that says one thing, another meta-analysis, if you design it a little differently, you have different inclusion, then it has a different conclusion. And I think what that ultimately tells us is what we already know, that preterm birth is multifactorial. There isn't going to be a panacea that's going to work for everyone. And one way to break down who is this going to work for is to look at risk factors or dose or gestational age of initiation. So, and this is looking at comparing outcomes this is actually, I realize the citation is wrong. This is from our trial. We had planned subgroup analyses based on cerclage, short cervix, prior preterm birth, and we did not find an interaction between those risk factors and progesterone efficacy. And for the most part, across risk groups, we still found a trend towards favoring vaginal progesterone in prevention of preterm birth. Similarly, we looked at subgroup analysis in the meta-analysis. I really wanted to be able to do a subgroup analysis by cervical length because there's so much data suggesting that short cervix plus preterm birth does put you in a different risk group and it does seem to be additive. But unfortunately, because so few trials included patients with short cervix, the data was really limited. And so there's the few patients from our randomized trial and one other trial. And so it's really hard to draw any conclusions on whether there is a difference in vaginal progesterone versus 17-OHPC based on cervical length. Our data doesn't seem to show that there is.
So like you say, there are other people who have looked at some of this data on progesterone and done, large, even individual patient level meta-analysis. One of them is the EPIC meta-analysis that was published also recently in the Lancet last year and got a lot of publicity. Why don't you walk us through that and kind of compare to what you've done?
Yeah, this was a tremendous effort, and I think we were all waiting a long time for it. But it took a long time because they really did a lot of work and doing an IPD meta-analysis. So this was looking at progesterone for prevention of preterm birth, period. So they included short cervix, prior preterm birth, whatever the indication is, singleton, multiples. So the overall conclusion of the meta-analysis was that both vaginal progesterone and 17-OHPC were effective in prevention of preterm birth in high-risk singletons compared to placebo. So again, this isn't comparing them directly. It looked at each compared to placebo. Both of them were found to be effective. The strength of effect seemed to be stronger for vaginal progesterone. They did a network meta-analysis, so an indirect comparison of the two. And although it wasn't statistically significant, again, the strength of effect seemed to be greater for vaginal progesterone. They also, because they had all this IPD data on placebo-controlled trials, they also looked at, this is just looking at outcomes in the patients in the placebo group. So it's women who are not patients who didn't get any intervention. And it's really giving us a natural history of preterm birth in patients with risk factors. The red line, and this is again looking at latency to delivery. The red line on the outside is patients with a normal cervical length and no prior preterm birth. The green line is normal cervical length, but with a prior preterm birth. So you can see a drop in your latency to delivery just with that prior preterm birth history, even with a normal cervical length. And then you get a big drop when you get to your group of patients with a short cervix. So the blue line is short cervix without prior preterm birth, and the purple line is short cervix with prior preterm birth. So you can see you have this additive risk of prior preterm birth adds a little bit, short cervix adds more, but even within those with short cervix, with a prior preterm birth, you're really in that highest risk group. They also tried to look at if there was interaction between risk factors and efficacy of progesterone. I think this is a great effort. And I think this is, we need more work like this. Of course, it was a meta-analysis, so it's limited by the inclusion criteria of the studies and the study characteristics. So unfortunately, most, as you found in our meta-analysis, most studies were either short cervix, no prior preterm birth, or prior preterm birth, no short cervix. So it was hard to, their ability to determine the additive effect was limited because the number of patients in trials that included both was limited. But in general, I think they did, what's important is they did see some interactions between preterm birth history and short cervix and progesterone efficacy. So the conclusions that you can draw are limited. I can't give you like a specific effect size or this isn't enough to change management, but I think it's enough to show us that these are important characteristics to consider when you're talking about progesterone efficacy.
So over 45 minutes, we kind of did a humongous, review of a lot of data. It's not all the data, but I think it's the best data, out there. It's interesting how different people can read some of this data differently, and also how, like I said before, the pendulum keeps on swinging, because go over this slide, it's interesting how societies, as of now, and, some of these have different dates, but these are the current ones as of, June 1st, 2022, these are the current ones. They recommend, and this, we're talking about people with a prior spontaneous preterm birth carrying a singleton gestation. They all recommend progesterone, interestingly enough, but go over the details.
Yeah, so I love this table because I think it's also important to see what's happening all over the world and not just what we do in the US. Although you can see in the US, we can't even agree exactly on what to do. So ACOG, following the EPIC meta-analysis, ACOG had published an updated guideline on preterm birth prevention. And they specifically said to consider either vaginal progesterone or 17-OHPC for prevention of preterm birth. And they additionally recommend cervical length screening, which we can talk about in a little bit. But they recommend either or, and they don't recommend one over the other. They do highlight the findings of EPIC, which also suggested that the strength of evidence might be greater for vaginal progesterone, again, in general in preterm birth prevention. But either or options. SMFM still maintained 17-OHPC weekly and didn't make as strong a statement about considering either or. There's just, 17-OHPC. I'm not sure if they're planning on updating that anytime soon. It hasn't really changed after Prolong or after EPIC. It didn't change significantly. It went from being recommended to consider and discuss risks and benefits. NICE, which is the group in UK, it's National Institute, I think, for Clinical Excellence. I don't want to say it wrong. They have recommended vaginal progesterone suppository daily at least since 2019. I don't know if the earlier versions did, but this was a 2019 recommendation. Their recommendation was based on their own meta-analysis of data looking at vaginal progesterone in prevention of recurrent preterm birth. They don't even talk about 17-OHPC at all. Similarly, the Society for OBGYN in Canada also recommends vaginal progesterone. FIGO recommends either one or the other. So the society recommendations don't give a lot of help in telling you, what you should do, although vaginal progesterone is represented more broadly across international societies.
I've been part of ESWOG as well, the International Society of Ultrasound OBGYN, and I don't think they will mind publicizing the fact that their guidelines for prevention of preterm birth are coming soon. Actually, their guidelines for second trimester anatomy scan just came out, and they're going to side on the side of vaginal progesterone. So I think overall, it sounds like the majority, do point to vaginal progesterone, as you can see in the blue in the slide, and an ESWOG. And maybe this live stream and your randomized studies and gray and green and pink publications will change people's mind. I want to quickly go over a couple of minutes this meta-analysis that also came out in the gray very recently. In fact, the official PDF is not out yet. There's the initial kind of Word document, but Candia-Gudelo and Romero, leaders in this field, did meta-analysis of vaginal progesterone versus placebo mostly for this population, singleton with a prior spontaneous preterm birth, which I think overall kind of strengthen our arguments, but you can look at this data many different ways. Overall, they had significantly less preterm birth, less than 37, less than 34 in NICU admissions with the vaginal progesterone group. They did have several trials, and only 3 were low risk of bias, which they had a trend for benefit, but that was no longer significant. So you can also read this, we need more data, and we always need more data. That's why I go back to the Temple of Apollo at Delphi and the fact that certainty is madness. We're not certain, but again, this data seems to point to vaginal progesterone working. It's interesting that the 3 low risk of bias studies were by O'Brien, an excellent large study, which excluded short cervix, which we discussed before. I think it's excludes the patients who may eventually benefit the most. And most importantly, they published, Dr. DeFranco from this group published a secondary analysis showing in their data that if you started vaginal progesterone in women with a prior spontaneous preterm birth compared to placebo, your incidence of short cervix decreased. So while in the trial they didn't have many short cervixes, in their overall data set, they showed kind of what we're trying to show. We hope to show the vaginal progesterone not only decreases preterm birth in these women with a prior preterm birth, but does so by decreasing cervical length. I think that's one of the best arguments for this to work. The Optimum trial, very famous by Dr. Norman, did have a trend for benefit, less preterm birth, but lower preterm birth incidence in this subgroup of women with a prior spontaneous preterm birth, better vaginal progesterone compared to placebo. And last, the Crowther trial, another wonderful investigator and great trial. They really never reported on cervical length, and they also used a slightly different progesterone dose. So I think overall, again, there's a lot of discussion. A lot of people are discussing this important trial. I urge you to read it. But I think overall, you can't say this is the last word, but overall, I think the single trial included and the overall analysis points to progesterone helping. And, maybe we can go over this kind of last couple of slides and put it all together, Rupsha. I remember 2003, the pendulum swung wildly, towards 17p. And, everybody came out saying, this is panacea and we need to use it. And it's interesting how, Prolong came around, your trial came around, meta-analysis now in the pink. The pendulum may be going that way, and I'm not sure it's going to stay there, but go ahead.
Yeah, I just wanted to comment on, the last slide, looking at, it just highlights the importance of starting from the basics of how is this working and what is the pharmacology of what we're using. So is there a problem with the dose? Is 100 milligrams less effective, maybe not ineffective, but less effective than 200? Is it that aspirin prevents preterm birth? Aspirin reduces the risk of recurrent preterm birth. Is it that for some women, the risk factor profile or what the biochemical profile that they have that's predisposing to preterm birth, they would benefit more from antiplatelet therapies than progesterone therapy? So I think there's a lot that we don't understand, which gives these mixed results. But I don't think that mixed results means that something's not working. And so that's why, like you said, it's very important study, is a well-done meta-analysis. But you really need to dig into the details and see, what was the population included in these trials? Is that similar to my population? What are the risk factors? What is the intervention they're doing? When are they starting that intervention? And there's still a lot more for us to learn. But in looking at the last slide, in reviewing what we know to date, I think that there is the strength of evidence looking at from mechanistic translational studies to clinical studies is stronger for vaginal progesterone. I don't think that it means that 17-OHPC is not effective. Obviously, you have one very strongly positive trial and one very strongly negative trial, and a meta-analysis of many studies that found some benefit 17-OHPC. But from looking at overall of this data, that's how I counsel patients. And ultimately, you also need to take into consideration, is the patient going to take that medication? So if it's someone who says, like, I'm never going to remember to take something daily, then prescribing a daily medication is not very helpful. If it's, a problem, I don't know if it's unique to United States populations or not, but if it's a problem of access to medication, of trying to get prior authorization for approval versus prescribing an easy to obtain generic that you can pick up at the pharmacy and not wait for a mail order pharmacy. Those are important things to consider in whether, in what formulation is going to be best for your patient. Our study has found similar satisfaction and side effect profile and adherence over time. Although we did, like I said, found later start time with 17-OHPC. But all that means is that you need to talk to your patients about what kind of side effects to expect so that they don't stop it. And based on the side effects to expect, what kind of medication they would be most likely to be adherent to.
Yeah, I think this slide, took us a while to put it together, but we both agree on it. The effectiveness, the mechanistic part, you beautifully went over. Less side effects compared to 17-OHPC in this population, again, singleton, prior spontaneous preterm birth, the satisfaction data just went over. And then, I think it's important in real life, easier to obtain, so you can start on time and cheap. In fact, we have a question from Dr. Roman, our friend. Is there any rationale on starting progesterone supplementation at 16 weeks? Is there any benefit of starting sooner? Do you want to comment on that?
Yeah. So, unfortunately, what happens is what was done is what gets redone. And so studies initially started looking at 16 weeks, probably to avoid that first trimester exposure risk. We now have many studies on, at least on vaginal progesterone, not 17-OHPC, but on vaginal progesterone exposure in the first trimester for prevention of recurrent miscarriage, for IVF. And none of those studies have identified increased risks related to first trimester vaginal progesterone exposure, congenital anomalies, et cetera. And so I don't think that there's a problem with starting vaginal progesterone earlier. I know that there have been raised concerns, especially for synthetic progestins, with earlier administration and potential fetal impacts. And like I said, while vaginal progesterone has been studied in the first trimester for a number of other indications, 17-OHPC has not been similarly extensively studied. So I wouldn't suggest starting 17-OHPC in the first trimester, but I feel comfortable starting vaginal progesterone earlier. And, for example, for our patients who are already on it in the first trimester, we'll often just have them continue it. They're started on it by their infertility doctor, and just have them continue it for prevention of recurrent preterm birth.
And, I think part of this live stream is to send research ideas out. I think it'd be very ethical, to do a trial and, especially high-risk patients, maybe with the earlier preterm births, prior preterm births, to say,
yeah, especially, I think,
start at 16 weeks and some start at 10 weeks or 12 weeks. And I think that that makes a lot of clinical sense, because in general, for prevention of preterm birth, the earlier you study, you start something, is like, aspirin for preeclampsia. It's another example that usually the better the effect.
And especially for those patients who are at risk for, we think about the recurrent mid-trimester loss or short cervical insufficiency. And you ask yourself, well, should I start this earlier? They had PPROM at 18 weeks. Why am I starting something at 16 weeks? So,
yeah. And this is kind of the last slide we have, for many years, I think, Rupia, we hid here at Jefferson, we do so many randomized studies, so what do you do? And, we always say we randomize, Now that we've done the randomized studies and published the meta-analysis, I think if somebody is on 17P prior pregnancy, did well, wants to continue it again, somehow doesn't want to take a vaginal suppository every day, you covered this beautifully, doesn't maybe not remember, we allow them certainly, and we're open to that. But I think the pendulum has swung a little bit, given your data, to again at 16 weeks starting vaginal progesterone, and then we do cervical length screening. Like we say, it's in your studies 25%, sometimes 30-40% of these patients have a short cervix, and then we didn't cover, but cerclage by all guidelines is recommended, and continuing vaginal progesterone. And maybe this gestational age will change. We'll go to 24, 25, 26, 27 weeks as well, both in terms of progesterone screening, who knows, other intervention. So I think the last message is, again, certainty is madness. We're not selling holy water here today, but I think we have a ton more evidence that we had, back when you were in training, and I thank everybody who helped you, and thank you, and thank everybody who will carry the torch forward and will shed even more light also on the mechanistic part. You want to give any last comments, and then we'll wrap up?
I just want to emphasize what you said, that certainty is madness. And I think that progesterone is not a panacea for preterm birth prevention. And if you come into any study looking for it to be, you will be disappointed. And so it's important to take things in context, to look at the totality of data, to try to put together what would be best for the patient in front of you. But I think there's still, a lot more work to be done on what does it work in some patients, and why doesn't it work in other patients, and how we identify those patients that would best benefit from, whichever intervention.
Thank you, Rupia. It's been a pleasure. Thanks everybody for listening. We'll see you soon again on the next live stream. Thanks, and have a wonderful morning, afternoon, night, wherever you are around the world. Thanks for following. Have a great day.